I've been involved with the legal reference group for this project for about 18 months. It's good to see that it's finally come to fruition. Some of you may know it was initially targeted for those areas that were in the National Broadband Network, so concentrating on Coffs Harbour and Armidale and a few other areas. It was quite a slow rollout of the NBN. So we changed the government late last year for the places that were eligible for it. And due to the fact that there were a lot of DVA patients on the North Coast, and due to some motion from myself and Ms Mitchell, we're going for North Coast is the place to come to. So I hope we can put that right. So this evening we've got Tracey and Wayne who are going to from DVA and tell us about the CVC program. I think many practices are involved with the CVC, and I think that's a really excellent model for chronic care for elderly Gold Coast patients, and to extend the reach of practices of the medical home, a concept that's promoted by Tony Lemke. Things like telemonitoring can make a big difference in folks. I think wishing that this trial will prove in the next 12 months. We have tonight Tracey and Wayne going to do their presentation, and we've got Tunstall's who are going to show us how the equipment work, which is really cool. I love the techie side of things. And we're also recording this, as you've probably seen, from Peter Heiliger, one of our technical support people from the GMC up the back here. For those who can't get to this presentation, get some idea of what the program's about, how telemonitoring is for this.
Thank you. Yes. And thank you very much for hosting the event tonight. We're very grateful to you opening up your surgery and this wonderful meeting room. Thank you for everyone for coming along. Thank you to our Medicare local people for assisting with all the arrangements. It's wonderful. There are two parts to tonight's presentation. The first part, I'd like to talk about the Coordinated Veterans Care Program. How many practices represented here tonight haven't yet enrolled any patients on the CVC program? No? So everyone has enrolled patients?
I don't think we have
Okay,
yet.
you haven't?
No, Teresa's on her way to, so she's the manager of the practice, so as far as I know.
So look, I apologise to the practices that have already engaged with the CVC program. We'll probably go over some material you're quite familiar with, but it's for the benefit of the practices who haven't yet engaged. So my apologies in advance. We'll do the Coordinated Veterans Care Program first, and then we'll have a short break, so you can get some of the food which John will bring up shortly. And then Tracey will talk about the in-home telemonitoring for veterans trial, and we'll demonstrate the software, that equipment to you, and show you how it all works. And hopefully you'll all get so excited about the telemonitoring trial that you'll all sign up for it later on in the board trial, which is wonderful. I'm not going to read this poem to you, I'll let you read it yourself, but it's quite a powerful statement about the part of our Australian community the Department of Veterans Affairs is here to serve. Our veterans are an extremely valuable part of our community. We're very grateful to them for what they've done for us. And this, I think, sums up pretty much what we owe to these people. Just give me a quick second to have a read through that. I love it. That's who we're here to serve in the Department of Veterans Affairs. And you people in the medical practices are serving them as well, and for that we're extremely grateful. Thank you very much for looking after our veterans. Please, come on in. Unfortunately, you get the front row. Now, DVA, as a Commonwealth Department, is responsible for carrying out the government's policy for the veteran community. We look after not only people who have served in the ADF, but also their families, so their widows or widowers, and also their dependents, and a few other small groups of people we look after as well, including some serving members, current serving members of the Australian Defence Force. Our core business is compensation and support for people who have served, healthcare, and commemorations. And the government spends over $12 billion every year on the veteran community, and about over a third of that now is on healthcare. So it's a big chunk of money we spend on healthcare. An incredible range of services we can provide for our veterans, particularly our gold card holders. And you can see some of the items listed there on the screen. One of the handouts you can grab later to take with you does list all our DVA funded health services you are able to access for your veteran patients. It's a two-sided sheet, there's a lot of services available. This tells you all about those services, who they're designed for and how you can access them. Some of the other brochures that are here also talk about our DVA mental health services. There's another one there for our veterans and veterans family counselling service as well. So if you're not really familiar with the full range of services, please help yourself to those brochures afterwards. You'll find them very interesting. DVA delivers its services through a range of mechanisms. We have our own offices in each of the capital cities around Australia. We also have a series of Veterans Access Network offices, including one right here in Lismore. So you're very fortunate to have access to DVA directly on your doorstep. Take advantage of that. The people at the office here in Lismore are very wonderful people, very informative, and they can help you with questions about DVA services and helping you connect if you're looking at that as well. Other places around the country we use some contracted service providers like the Retirement Service Centre in Tasmania. Centrelink also provides services for us in a few places. Coffs Harbour, for example, we have a contracted officer at the Centrelink office in Coffs Harbour, who's the Veteran Community Support Officer there. But you can find full details of how you can contact DVA on our website, or you can just call the local Lismore office. We pay for our health services through a card system. We have 3 cards, the gold card, the white card and the orange card, which entitled veterans carry with them and bring to the medical practice. The gold card is the top level one. It covers absolutely everything. Anything the patient needs. Front centre for you. Covers absolutely everything. The white card also covers everything, but only for specific conditions that are approved by DVA. So if they have a particular condition, then we cover everything associated with that. Unfortunately, we can't tell you the whole range of conditions that a particular patient might be covered for, but if you ring DVA and say, is this patient with a white card covered for these services, we can say yes or no, and then we can charge up to that. The orange card is for pharmaceuticals only.
Is that confidential?
Yes, correct, yes. Yeah. So we can tell you if a particular service you're looking for is covered, but we can't tell you the whole range of services that might be entitled to. Not necessarily, no. Sometimes they do, yes they do, but not always. They'll try and get things that they bring in. But the gold card does cover pretty much everything. As at the end of November last year, we had about 167,000 gold card holders, so still a significant number of people we look after. You can see that most of them are in the older age group now, but we still have a significant number of gold card holders in the younger age group, even under the age of 40. Veterans who have been returning from Gulf War conflicts, peacekeeping operations and been injured through those conflicts are entitled to a gold card and they get it. And of course, spouses and family members of people killed on those conflicts are also entitled to a gold card and look after them as well. One of the things I like to remind medical practices is to not always think of a typical gold card holder as being someone 85 or older and a male or whatever. You could end up with a 22-year-old young mother with 2 children in tow come into the practice with a gold card, and that's quite possible. And the reason I emphasise that is because we have had instances of medical practices turning away young mothers with gold cards and accusing them of having stolen a veteran's gold card. So please, don't do that. Those are obviously spouses of veterans who've been killed overseas and they've got a gold card for that reason. And it's amazing what we can do with a gold card. You saw some of the services available before, but one story I'd love to tell does relate to one of our younger female clients who was the wife of a veteran killed in Afghanistan. Unfortunately, he was killed before they were able to have children, but amazingly they thought ahead and managed to preserve some sperm. Using the gold card, we were able to access IVF services for them. She now has a son. Amazing thing we can do. However, because most of our gold card holders are older, they do often suffer from chronic illness. 2/3 of our gold card holders have at least one of these 5 conditions alone: coronary artery disease, chronic obstructive pulmonary disease, congestive heart failure, diabetes, pneumonia. About 1/3 of our gold card holders have more than one of those conditions. So chronic illness is a significant issue for us, and one we've been wanting to address for quite a while. Hence the Coordinated Veterans Care Program. Nice to see you. It is a fairly innovative health program for gold card holders who have chronic conditions, complex care needs associated with those conditions, and who are at risk of unplanned hospitalisation. It's been operating for about 2.5 years now, and what we've been able to deliver and what's the experiences we're seeing are just absolutely amazing. I'm sure Dr. Guest can tell you some of the results that he's seen in his own practice, and I'm sure those other practices who have been with the CVC program for a while could also tell us some great stories about what it's doing. It is targeted at those 5 conditions we mentioned earlier, those 5 that are up on the screen. It's not limited to those 5 conditions, although we really would prefer these ones alone. But if you have patients, gold card holder patients with other chronic conditions who also have complex care needs and are at risk of hospitalisation from those conditions, you are able to put them on the program as well.
I'm sorry to interrupt, I do have a question. Chronic psoriasis. I have a patient at my clinic who has chronic psoriasis. Now, it falls under the category of social isolation for the CVC program, and it does potentially cause hospitalisations. What are your thoughts on that one?
The ultimate decision is up to the GP.
Okay.
The GP assesses them as being suitable and eligible. That's the GP's decision.
Okay. So it doesn't fall, like it's not, I don't have to ring you guys up
No.
and say, oh, is this case eligible?
No.
Okay.
No, absolutely not. Look, one thing I will say up front is we want to make this program as easy and as simple for you guys in the practices to implement as possible. So we don't have lots of paperwork, lots of really rigid processes. We're really flexible about this because our main concern is making sure that the veteran patients who need this care get it. All right. So in your particular case, if your doctor thinks that this would be suitable for that patient, go for it.
Great, thank you so much.
You're welcome. Okay, now in the early days of the program, we were using one of our partners for the program, Urban Health Dialogue, to assist us in identifying potentially suitable patients for the program. We were writing out to those patients. We were also writing to their usual GP, inviting them to get together and have a talk about the program, and if deemed appropriate, then signing up for it. We haven't done any active targeting for a while. What we are doing now is actually engaging like this directly with the medical practices, encouraging you to find out about the program, to look at your patient lists and to enrol them. One of the things we can do to help you, and we are doing quite a lot now, is we can provide you with a list of potential patients at your practice now who we think are suitable for the program. And we found that that's been a lot more successful than writing out. Okay, GPs can identify their own patients. Patients themselves may come to you and say, we've heard about the Coordinated Veterans Care Program. Is this something for me? Now, they may or may not be suitable. That's up to the patient to discuss with the GP again. And if the GP says, yes, this is for you, then put them on that way. It doesn't have to be identified by us. It doesn't have to be identified by the GP. It can come from the patient or their carer. There are some eligibility criteria. They must be a DVA gold card holder. They must live in the community. And what we mean by that is not living in residential aged care. Now, they can be in a retirement village type environment, provided they're still in the independent living part of that environment and haven't yet moved into the high care facility. I also need to add that they must be living in Australia. We have had some GPs who have patients who are living overseas. We're not quite sure how they're providing the ongoing quality care for patients living in Bangkok, but they must be living in Australia. Must have one or more chronic conditions, complex care needs associated with that, we've talked about that, and be at risk of unplanned hospitalisation from those conditions. And very importantly, they must consent to join the program. We can't drag them kicking and screaming onto it. They have to agree to do this. Must not have a condition which the GP deems to be terminal within the next 12 months. The reason for that is quite simply there's probably not an awful lot you can do for them under the banner of the CVC program that the GP is not already doing for them in palliative care arrangement. That doesn't mean to say that if after going on the CVC program, if they develop a terminal condition or diagnosed as terminal, they have to go off the program. They don't. If they're diagnosed as terminal after joining the program, they can stay. Mustn't be participating in another sort of coordinated care program, whether that's one run by the Commonwealth Department of Health, such as the Extended Aged Care and Home type program, or a state coordinated care program. There's no point in doubling up. So long as they're getting coordinated and planned health care under a program, that's all we're worried about.
There might be a coordinated care program with the area health service and GP practice.
Correct.
I think you promise that you won't target DVA.
Look, we don't mind if you do, so long as we're not sort of doubling up. There's no point in doubling up. So what is it all about? Look, this model of coordinated care is about a GP-led team care arrangement. A GP and a nurse coordinator planning and coordinating the health care for these chronically ill patients. The GP determines eligibility and suitability for the program, and if both agree and consent, then the GP enrolls them in the program, and all that means is simply lodging an incentive claim. We'll talk about the payments later, but there's no enrolment forms or anything to fill out. You just submit that claim to Medicare and they're on the program. The GP then develops a comprehensive care plan, and the nurse coordinator takes over from that point and implements the care plan, maintaining regular contact with the patient, helping them to connect with whatever services they need, whether they be medical specialists, DVA services like the Veterans Home Care Program, or other state government or local community services, and just making sure that they're okay and they have everything they need. Liaising back with the GP on a regular basis to let the GP know how things are tracking, seeking advice maybe if they might need to make some changes to their clinical arrangements and so forth. One of the things we do provide for you to help you in that role is patient treatment report. I'll come back to that later on in a bit more detail, but in short, it's a report of all the hospitalisations, medical treatments, tests, medications the patient has had in the last 12 months that we are aware of at DVA. But I will come back to that later, which will get all the information. Social assistance. This is a very important aspect of the CVC program that we have introduced in recognition of the effect that social isolation can have on people with chronic conditions, and vice versa, the effect that chronic conditions can have on people's level of social interaction. Too often people who have chronic conditions end up in a downward spiral of social isolation. That's what we're trying to break here. It's a service which is part of our Veterans Home Care Program, but only available for CVC patients. It's a short-term intervention only, maximum 12 weeks, designed to help and encourage people to get back up on their feet again socially, integrating with their social networks on their own, and then we sort of withdraw and let them carry on. If you think you have a CVC patient who might be suitable for that service, you refer them to your local Veterans Home Care Assessment Agency in the same way you would for any other VHC service. The assessment agency will contact the patient, determine whether or not they're eligible or suitable, and then talk to the patient about an activity that might be suitable for them. There's no mandated activities. It could be joining a walking group, craft club, maybe a bridge club, maybe even Wednesday afternoon bingo down at the local RSL club. Whatever the provider and the patient agree on. DVA will pay for transport for that patient to and from the activity, and for someone to accompany them to that activity and encourage them to participate and take off from there. So don't forget about that. It's a very, very useful service. Okay, payments. Hands up all the practice managers. Yeah, okay. Pay attention. We do recognise what we're asking the practices to do in some cases is more than what they're already doing with their patients. Some practices are already doing a lot of this, others aren't. We want to recognise the effort that you're putting in, and so we do compensate you for it. For practices that are already doing it, we want to make sure you've got the resources to continue being able to provide that extra service. There are two payments associated with the CVC program, an initial incentive payment and a quarterly payment for providing the ongoing care. Each payment is on 2 tiers, depending on whether you're implementing the program at your practice with a practice nurse or without a practice nurse. Okay? If you can't implement it with a practice nurse, most practices do it with a DVA contracted community nursing provider, or an Aboriginal health worker, or the GP may decide to do it on their own without a nurse coordinator. That's also possible. But if you're not using an internal practice nurse, then you'd be claiming the lower tier of payments. An important thing about these payments you need to be aware of is that they're over and above any other Medicare items you're entitled to claim. So in addition to your consultation fees, your GPMP fees, your GPMP review fees, home visit fees, over 75 assessment fees, all of those, you can still claim all of those in addition to these extra CVC payments. So it's extra. Don't forget about that. Don't stop claiming all your other items as well. As you can see, quite lucrative, about $2,100 per patient in the first year and about $1,700 per patient for every year after that. In conjunction with the Australian Medicare Local Alliance and Flinders University, we've also developed a really comprehensive and state-of-the-art training and resources package in chronic disease management. There are 4 online training modules available. If you don't want to do them online or can't for whatever reason, you can get a hard copy version of it and a CD, which you can take home and work through at home. They are also accredited, so both GPs and nurses who undertake the training can get accreditation points for it. It's not mandatory. You don't have to do this before you can engage with the program. It's there as an option for you if you need it. But we do recommend it, particularly if you haven't done any other chronic disease management training before, we do recommend it because it is great stuff. It's not specific to the CVC program, so you will be able to use the benefits of this with your other chronic patients as well. And yes, it's generic. Oh, and it's free. There are no charges to this. It's free access. You can get access to the training and resources on that particular website there. In addition to the training modules, there's also a stack of other resources. So, for example, if you don't have a care plan template in your practice at the moment, and you're looking for one, there's some care plan templates up there you can have a look at and use if you choose. There are assessment tools like the Kessler K10 tool are also available on that site, which you can draw down. There's a number of other things available for you as well there to help you with chronic disease management. We mentioned the patient treatment report earlier, and we mentioned that it is a report from DVA to you as the practice looking after the patients of all the hospital episodes, medical treatments, tests, medications the patient has had in the previous 12 months. So the first version of that comes out to you in hard copy by post within a month of first enrolling the patient on the CVC program. After that, they're available quarterly in electronic format on the health professionals online service. If you don't want to use the health professional online service for whatever reason and you find it difficult or whatever, you can contact the CVC provider helpline telephone number and just ask to get them in hard copy format, and you will continue to get them in hard copy format. So easy as that. Now, one of the main reasons we're up here on the North Coast of New South Wales this week is to talk about the in-home telemonitoring veterans trial. This is an extension of the CVC program, so it's for CVC patients, but we're only running the trial for 300 veterans around Australia. We started the trial in the Armidale area of New England. We've also rolled it out in the Torngadale Downs area of southern Queensland. And the third area we're rolling it out is North Coast New South Wales, in the area from Twin Heads down to Coffs Harbour. That's the area we're targeting. And we are looking to run the trial up until the end of June next year. So we're up here at the moment recruiting practices who might be interested in participating in that trial. The The trial is all, I'm not going to go into a lot of detail because Tracey will do this later on, I don't want to steal the thunder, but it's about placing a computer tablet in the patient's home. We pay for all this, and certain peripheral devices that allow the patients to take their own observations at home. Those details are transmitted over the internet to a central database, and you in the medical practice can access that information online and see how a patient is tracking. That's in brief what it's all about. It's very exciting technology, and before you say anything, yes, 85 and 90-year-olds do use this equipment. They learn it very, very easily, and they love showing it to the grandchildren. Look what I've got. It is very easy to use. Training is provided to the veterans. The equipment is installed in their home. They're given all the training they need. We don't leave them until we're confident they know how to use it. We also teach you in practice how to use the back office software to go on and have a look at the various readings and stuff, how to use the software. Okay, now, this is not designed to replace face-to-face access with the GP. If they still want to or need to see their GP, they can. It's also not designed to replace standard emergency procedures. So if they're not feeling well and they would normally call 000 or their care or whoever else, that still happens. This is simply allowing the GP to monitor their vital signs over a period of time without them having to come into the practice to have those orders taken on a regular basis. Particularly useful for patients who live some distance from the practice or who have transport issues or medical issues. Okay, but we will in the second part of the presentation we'll give you a full demonstration of the technology and learn how to play around with it. So where we're at with the CVC program. I mentioned earlier that we did undertake a formal targeting exercise for a while, and while we were doing that, we did manage to target about 20,000 gold card holders, but obviously there are a lot more out there who are potentially suitable for the program. As at the 7th of February this year, we had nearly 23,000 people had enrolled in the program. Nearly 5,000 GPs around Australia are engaged with the program. And a lot of those are in North Coast New South Wales. We've got a lot of practices in this area engaged with the program, probably because we've got a lot of veteran clients up here, which is good. We're averaging about 100 new participants or enrolments every week, and 96% of the GPs involved with it are enrolled patients using their practice notes. We're very grateful to have the support of many GPs, including Dr. Guest, but Dr. Steve Hamilton is one of our greatest advocates as well. This is one of his quotations about the CVC program. We're very grateful for your support. The AMA back before Christmas 2012 released a white paper on chronic disease management for the wider Australian community. And in that white paper, they were espousing a model based on the CVC program. In fact, many of the terms that Dr. Hamilton used in that paper were CVC terms. But last year, they went one step further. During the election campaign last year, the AMA released a health issues paper where they advocated a chronic disease management model for the wider Australian community, quote, based on the Co-Ordinated Veterans Care Program run by the Department of Veterans Affairs, unquote. So we think we might be onto something. We do have 3 contracted service providers assisting us to implement this program. I did mention Bupa Health Dialogue earlier. Don't confuse them with Bupa Health Insurance. This is another arm of the global company whose expertise is in a number of areas that we use. One is to analyse our health claims data and determine who might be suitable and so forth. They're helping us also with patient treatment reports. They will prepare those patient treatment reports again after analysing all the healthcare data. The provider helpline, which you might call if you have any queries at all, is staffed by Bupa people. But don't let that put you off. They do know the CVC program inside out and back to front, and they'll be able to answer just about any question you have. If they can't, they'll escalate it through to us and we'll get back to you. The Australian Medicare Local Alliance, in conjunction with Flinders University, developed the training and resources package for us. And Grosvenor Management Consulting were brought on board right at the beginning of the program to help us independently monitor and evaluate. A little unusual for government programs. You often find government programs don't start talking about evaluation until after the program's over or well down the track. CVC did it a little differently. We brought them on right at the beginning, and they've been reporting back to us on a regular basis about how they see the programs performing against its objectives, and that allows us to make fine-tunings as we go along. And part of that process of fine-tuning, we consult our clinical reference group, on which Dr. Guest is a valued member. So we often go back and seek their advice on possible changes to the program. Okay, important messages. The CVC program is a targeted program. We're looking at gold card holders who have those 5 targeted chronic conditions, but again, it's not limited to that program, to those people. So if you have other patients, as we discussed earlier, just make sure they meet the other eligibility criteria in terms of being a gold card holder, living in the community and so forth. If you need or would like a list of the potential patients at your practice for the CVC program, don't hesitate to give us a call. You've got my business card there, you can drop me an email or you can call me and I'll run the list off for you and get it off to you in the post. That's not to say you have to enrol all those people, but it's a little starting point for you. So if you're having to troll through all the patient records yourself and work out who might be suitable, we'll give you some starts. After you enrol a patient on the program, we just ask you to make sure there's a healthcare plan, comprehensive care plan in place for the patient. We also strongly encourage a patient-friendly version. And we don't mean rewriting the entire plan in a different language the patient can understand. We're looking at just a single page, something they can stick on their fridge at home as a daily reminder to them of the key points of the program. So if you set some goals with the patient that you agreed that you're going to try and achieve, you can put those goals on there. If there are some things that the patient has said, yeah, I will do that as part of looking after my own healthcare, you can just put those things up. You know, for example, they might say, I agree to walk down to the leisure box and back every day to increase my exercise load. That's a reminder to them of what they've committed to do. Medications, often practices find it helpful to list the medications the patient's on if there are a lot of medications with instructions on how to take them. But just a single page that's a reminder to them of what they need to do and what is being done for them on a daily basis. And then make sure you just provide the ongoing care. One of the, while we're on that point there quickly, one of the myths about the program is that you have to have the patient come into the practice at the end of every quarter before you can lodge that quarterly care claim. You don't. Provided you've been providing that ongoing care throughout the quarter for support for them, every 90 days you can lodge that quarterly care claim automatically. E-health records. I'm not sure how many practices might be engaged with e-health records in this area, but look, we think it's very important for our veteran clients for a number of reasons. Because they're elderly and frail, they're often seeing a range of medical providers, specialists, they're going into hospitals. It's really important to make sure everybody's working on the same page and has access to the widest range of information available about the patients. We think the e-health record is a great way to do that. Unfortunately, the standard registration process for the e-health record is not as good as it would be, not as easy to use. So we really strongly encourage assisted registration for veterans. In fact, not only for veterans, but the latest figures I saw out of the Department of Health said that more than 2/3 of registrations for the e-health record around Australia were through the assisted registration process. So I think that sort of indicates to you how easy it is to use. Look, there's a number of ways you can do it. Some GPs offer assisted registration for it. Often there are community events. The Medicare local here in this area, I know, often runs assisted registration events, or can come into your practice and do an assisted registration within your practice. There is an e-health helpline number which will do assisted registration over the phone. It takes about 5 minutes. It's pretty easy. And if you're looking for more information on the CVC program, there is the DVA website and also the Training and Resources website. Here on the table, there's a range of information available for you. There's the Guide for General Practice, which is pretty much the Bible. Everything you need to know is pretty much in that there. There are 2 smaller brochures about the program in brief summaries, one for practices and one for veterans. If you're looking for some information to give to a veteran you're thinking about enrolling in the program, you can give them that. All these documents are available electronically on the DVA website. There's the brochures I mentioned earlier about the range of DVA health services that are available. There's a brochure there on the Health Professionals online service and another one on the chronic disease management free to help yourself to those afterwards. Any questions at all on what I've covered so far, or have I actually bamboozled you?
I have one. The needs assessment that you do before the care plan,
Yes.
I'm getting confused. It's very ambiguous in the reading I've done. Do you do it at home or do you not?
Okay, home visits, good point. One aspect of the CVC program which we do encourage is a home visit. We strongly encourage a home visit as soon as possible after enrolling a patient so that you can see if there are any aspects of their home environment which may be impacting their health, and then you can build those aspects into the comprehensive
You
care
have
program.
you have to go into the home once in the 12 months, don't you? Once every 12 months.
Yes. After doing that initial one, the frequency with which you do the home visits is up to you. We do recommend it at least once a year, just to make sure that nothing has changed since the last visit. If you're able to do it more often, or if you think a particular patient may need it more often because your last visit reveals some issues that you want to keep track of, then do it as often as you think is appropriate for a patient, and as often, of course, as the patient wants you to use their home. Some patients don't like it very much. Look, the other assessments, things like the Kessler K10 and so forth, which you may choose to use, you don't have to do those in the home. You can do those in the surgery when they come in. The purpose of a home visit is primarily to see if there are any aspects of their home environment which may be impacting their health. Risks, forward risks. Maybe you have a sink in the fridge and notice there's absolutely no food there, not eating properly. Those sorts of things which you can eyeball in their home environment. One of the tools which we provide on the training and resources side is a sort of a checklist that you may choose to have in the back of your mind when you go into a home. You know, if you're not sure what sort of things you should be looking for, it's a suggested checklist. You don't have to sit there in the home and go check, tick, or anything like that. It's just something that you can keep in the back of your mind when you are dropping into sleeping.
I think I looked at the frequently asked questions section for the GP or for the practice nurse, sorry, and it said if the patient lives in a reasonable distance, it is expected for us to go there.
Yes, but we also recognise that there are often reasons why a practice can't do home visits. A number of corporate practices have policies which prohibit home visits. Occupational health and safety is sometimes an issue for a particular practice. Insurance can be an issue. How do they get there? Who's paying for the transport? You know, is there a vehicle available? There's a whole range of reasons. The patient may not want you to come into their home at all. So we recognise that all these things may prevent you from doing it, but we don't want you to not put a patient on the CVC program just for that aspect.
Okay.
So if that's an issue for you, leave that part of it aside and move on with the other aspects of the CVC program. Just make a note in the patient's file that you're not doing home visits for whatever reason, and then engage with the other aspects.
Okay. Great. Thank you so much.
You're welcome. Any other questions at all?
I'll just make a comment moment. I think having a list of patients that we're targeting is really important, particularly this is a group that's been shown to have potential for recruitment, avoid hospital admissions. We want to get those numbers fairly high.
Yeah, so look, if that's going to be a help to you, don't hesitate to drop us an email, and we'll print the report off for you and send it off to you in place.
And I do have a number of reports here for a number of the practices that are here tonight. I can go through and see if we have them. If I don't have a copy of your practice, I can get back to the office, printed and faxed to you ASAP.
All right, so look, we'll call a break at that point. There is some food available, help yourselves. Feel free to come up and ask any other questions. 10 minutes?
Yeah, sure.
10 minutes and we'll reconvene. Bring the food back with you to your seats, and we'll start on the telemonitoring drive.